So greetings everyone who is here. I am Caroline Gooden, the Director for Project Scope, and we are delighted to have you here for our fourth session of this fall series. Just a quick review of the dates and topics that are coming up. We have Tanya and Amanda to speak with us today. We're really excited about the content they're going to cover. The next session after that is 2 weeks from now with Miriam Silman talking about trauma-informed approaches. And just to note that the next session after that is the immediate week after that. So we'll go October 19th and then October 26th. And then we'll pick back up alternate Tuesdays through the rest of the series. Christine.
All right, and yes, we are grateful for our facilitators. So these are pretty much the same folks that we have been having that covered last week. Oh, I see Hans put the name of that series that is coming up on Hulu in the chat. Yes, I'm curious about that. Thank you. So yes, thank you to our amazing facilitators and for each of you for joining us here today. And here is our schedule. This should be fairly familiar to you. We will be moving into our content shortly, and it is with Tanya and Amanda. And Tanya is actually playing dual roles today, both our content expert along with Amanda. And so this is a real important topic and very impactful. So I know that you will really enjoy it. We will shift into our child challenge after the presentation, and then of course do our small group discussion work, and then come back together to just kind of debrief and share some of the highlights that we may have missed, given that we can't be in 6 breakouts all simultaneously.
So just a few reminders of procedures for our calls. Some people's first session. We're inviting people to drop in any point they can during the series this time. So please include your first, last name, and agency name in your Zoom profile for attendance. And also we ask you if you're willing to be part of a group resource list where we can network with each other in terms of our areas of interest and expertise. If you would put that in the chat as well. So if you feel like you have areas of expertise that you could share with your peers, if you would please put your name, email, and your area of expertise in the chat as well. And we're going to put together a list of all of us and areas of expertise so that you can contact each other after the series and during the series.
And I'm just going to add something real quick, Caroline. So even if you don't consider yourself quote unquote an expert on something, but like you're really interested in a particular area, definitely put that there, because we really want some of our like-minded folks to be able to connect with one another. So, if you're just like really interested in sensory processing, say, go ahead and provide that. So expert or, budding expert, we'll accept either option.
Good point. We ask you to keep your cameras on unless, of course, you're sick, and your sound on during the small groups. And we remind you that sometimes we talk about sensitive topics, and we encourage you to take care of your needs during each session. Do what you need to for you. And we ask you to continue to protect the confidentiality of all the children and families we discuss. A couple other reminders. We use person first language here. Our sessions are recorded. Brandon, are we being recorded yet? I didn't even think to ask you.
Yep, we're good.
Okay, great. There's also closed captioning. If you want to use it, you can turn that on in your Zoom settings. Feel free to ask questions anytime of Tanya and Amanda in the chat. This is a judgment-free zone. All viewpoints are respected here. We encourage you to send your child challenge for our next topic, which is supporting families through a trauma-informed approach. If you have child challenges you'd like us to discuss, please send them to me or Christine. And next, we're going to just talk about some of the great resources and strategies you came up with last time for Jaden when Dr. Grisham was presenting. So you all talked about the strengths for Jaden and his family. He's able to develop positive relationships. He's got good verbal communication skills, good motor skills. He's curious. He asks and answers questions, and he plays with toys appropriately. And he has a strong relationship with his grandmother, who provides a really loving, secure environment for him. Some of the great strategies that you mentioned for Jaden: using trauma-informed therapy. using a weighted blanket or stuffed animal to help him sleep, watching classroom routines and see what might trigger behavioral upsets. Encourage him to draw pictures of how he feels if he can't tell us that, and help him name the feelings that he has. When we see him getting upset, we might say, "It looks like you're mad." Use the zones of regulation chart and alternative behaviors. So for example, what can we do when we're feeling in the red zone? And give him some words for alternative behaviors. And giving his grandmother some ideas for independent play at home. They're all great strategies for Jaden. You all listed a number of resources and agencies for him, including the Family Nurturing Program. All of these have links as well. And you have these slides also where you can click on the links and look into these resources. Early childhood mental health programs across the state, grandparents raising grandparent support groups. All those are great resources for Jaden's family. A couple of terms that you'll hear today, and Tanya and Amanda will define them further for you. We'll talk about substance use disorder, or sometimes called abbreviated as SUD. We'll talk about addiction, and we'll talk about the important role of peer support specialists. Brandon, you want to talk about Zoom points?
Sure. So our resource page is up to date. So there you can find, the slides for today and all of our previous sessions, recordings of our previous sessions, and information on CEUs, if that's something you are after. If you got any questions about any of those resources or how to access that, shoot me an email. That's right there, and I will be happy to help. Thank you.
Thanks, Brandon. So to begin introducing our speakers for today's session, again, we have Tanya Jernigan and Amanda Metcalf. And I'm going to see if I can get to stop sharing for just a minute so I can tell you about our esteemed guests here today. So Tanya and Amanda have both been involved in SCOPE, both for this session and our last fall session, and we appreciate their continued support of this program. Tanya is a licensed clinical social worker. She's currently social worker at UK Healthcare in pediatric forensic medicine. She has a Bachelor of Arts from Transy and a Master's in social work from UK. She has 16 years experience in the fields of advocacy and social work. She's well versed to talk about this topic today. She began her career working in the fields of violence against women, first as a family advocate in the local domestic violence shelter, and then serving as a victim advocate in Fayette County Attorney's Office. Her experience as a social worker has mainly been in the field of substance use disorders, serving as a frontline clinician for pregnant and parenting women at Chrysalis House here in Lexington. She was the clinical director for Chrysalis House and oversaw the 62-bed facility, which serves pregnant and parenting women for the women and their children 2 or younger who live there full time. So to tell you a bit about Amanda Metcalf, we're also delighted to have Amanda with us today. She's a certified peer support specialist and a smart recovery facilitator. She's the family leadership coordinator for Kentucky System of Care grant. She's a certified family and adult peer support specialist, and she's worked with her local community mental health center for 8 years. In that position, she's collaborated with many System of Care partners, including providers for mental health, substance abuse agencies, juvenile justice, child welfare, and others. She supports families in navigating multiple service agencies and empowers them to advocate for the needs of their children and themselves. She's passionate about supporting and encouraging families in Kentucky to recover and live the life they want to live. So we're delighted to have Tanya and Amanda here, and I will turn it over to you all.
Okay, I'll try to make sure I'm not muted throughout this. So thank you guys so much for joining us today. Make sure everybody can see this. So everybody hear me okay?
Yes.
All right, perfect. Okay. So yeah, we're going to spend a little bit of time just talking about how we can have respectful conversations with families experiencing substance use disorders, and how we can use peer supports to really not only, I think, enhance our own knowledge of substance use disorders, but also to support the families that we serve. So the first thing that I want to do is just do a quick activity with you all. So I'm really quickly going to stop and switch screens so that we can do that. All right. So I want you to, if you can go to menti.com and then you just type in this code. All right. And I want you to just type in the first word that you think of when you hear addict. Please don't censor yourself. Just type the first word that you think of. I know that Caroline mentioned using language that's non-judgmental, but for this activity, I just want you to put in whatever word you think of when you hear the word addict. And hopefully we'll start to get some results here.
I typed something in, but it's not
You don't
working.
see it? I know, I don't see it. See, this is why I hate doing these. This is why I hate technology.
I think sometimes you have to refresh on this app.
Thanks. Let's see what happens.
Tanya, I see some people are putting those in the chat box as well.
Thank you. Maybe that might be smarter. I'm sorry, guys. This is why I do. Oh, maybe. Look at that. There we go. Now it's working. So, yay. And I see some people are still putting some words in because it's changing a little bit. So the cool thing about these word clouds is the more people who put the word in, the larger the word is. So I'm curious, anybody just chime in. What kind of surprises you about the words you see on the screen? Anything in particular?
They're all negative.
They're all negative. Most of them are, yeah. Really, the only thing positive I do see is family. Yeah, that was a good observation, April. Anything else? So how do you think these words impact the work you do with families? So if these are kinds of the things that you think of when working with families of substance use disorder, how do you think that's impacting the way you interact with them on a daily basis? If anybody's brave enough to say.
I like to say that those words speak of someone that needs help or someone that's in some type of lack and doesn't have everything they need.
Okay. Good, Annette. Yeah. So that recognition that these individuals need help. Good. All right. Anybody else? Awesome. I want to thank you guys for being brave enough. I know that's kind of scary to kind of be willing to put yourself out there and potentially put some negative, maybe words that might be perceived as negative on there. But, I think the first way that we can really start to address any of the biases that maybe we're kind of carrying around, and some of it happens from our own trauma, is to really start to just kind of dig down deep and identify those. And that's how we can kind of work to change our own mindset. So that's awesome.
Yeah,
Thank you, guys.
Taisha shared that her comment was, we already judged them. So I'm not sure if you saw that or not.
No, I didn't. Thank you so much. All right. Okay, awesome. Thank you, guys. So a little bit of information about who are substance exposed babies. So a substance exposed baby is not just a baby that's been exposed to opioids. And NAS does not just mean a baby's mom has used opioids during pregnancy. A baby can withdraw from any substance after being born. That could be nicotine, that could be caffeine, or prescribed medications that a mom was on during pregnancy. So again, substance exposed babies aren't just babies that have been exposed to illegal substances. And so I think that's important to recognize that I think as the mainstream media has really talked about NAS, we've mostly just focused on babies who've been exposed to opioids, and that's definitely what we're talking about during these sessions, but it's also important to recognize that there are other substances as well. And a substance exposed infant is not an addicted baby. So babies are not addicts. So if you go back and you think about some of those words that some of you thought of when we hear the word addict, what do we think of? I guarantee you that none of those words would you describe or use for a baby, right? So like when we really think about addicts, we can't actually consider babies to be a part of that, if that makes sense. So why aren't babies addicted? So addiction is defined, and I'm going to read this because I think it's incredibly important that we all understand how we define addiction in this field. It's a treatable, chronic medical disease involving complex interactions among brain circuits. So we know that the brains of individuals with a substance use disorder are very different than the brains of us who do not have a substance use disorder. Genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. All right. So when we look at this definition, we can see that it's impossible for babies to be addicted to substances. They can be born with significant withdrawal due to exposure, but they are not addicted. And it can be shame and guilt perpetuating to refer to babies who have been exposed to substances as addicts, not only to a growing child, but also to the family of that child. Many, if not most parents wanted to stop using substances during pregnancy. And all the work that I did with women when they were in treatment, most of them pregnant and parenting women, all of them wanted to stop using substances. And they're very aware that their continued use led to their baby suffering from withdrawal. And so constant reminders of that through shame-inducing language doesn't actually bring individuals closer to recovery, right? So sometimes the words that we're using push people away from us. They don't pull them towards us, which is what we want to happen when we're trying to help people through their journey of recovery, all right? So why aren't babies addicted to substances? So first and foremost, they haven't had that complex interplay of the environment and life yet, right? So they can't have compulsions and they can't have continued use despite harmful consequences, right? So when we think about continued use despite harmful consequences, when we're thinking about adults, that might be things like, having an overdose or a severe infection from IV drug use or loss of housing or employment or arrested or loss of custody of their kids. And then continue to use substances, right? Babies don't have that. And again, babies are born with a withdrawal syndrome, not an addiction to a substance. Right. So a part of the family. And I think this is the most important piece, I think, of this. One of the most important pieces that we're going to talk about today is, as a child care worker, you have an intimate relationship with the families you serve. So when we're really thinking about it, and when I think about the amazing child care workers that my children have had, you all probably spend more time with these children, at least when they're awake, than some of their own parents, right? Especially those working parents. So you really are a part of the family and serve an important role in the lives of these children. Many of the parents with SUD have experienced generational SUD, right? So they grew up in homes with substance use disorder. They may not have been parented by their own natural parents, or if they were, they may have had some pretty significant traumatic caregiving because of their parents' substance use disorders. And parents, so even those who aren't first-time parents, right? Because we sometimes come into contact with families with substance use disorders who have other children, but the child that you're working with them, that might be the first child that they've actively parented because of their history of use and trauma. And so, I always think of them as being incredibly thirsty for knowledge, right? Like they really, really want to do something different for their kiddo. I think just naturally speaking, I think most of us would say that we want to be able to provide or do something for our kids that wasn't done for us. And so they're looking for guidance and they're looking to you for that, right? Like they consider you the experts. We talked about, kind of what was your expertise at the beginning of this call today. And to them, your expertise is understanding children. And so you're going to play a really important role in setting the stage for success of these children. And most importantly, for their parents, because healthy kids can't come unless they have healthy caregivers, right? Those two things have to come together. And so you're really providing good guidance, advice, and knowledge about milestones. But you can't provide that really good expert advice and guidance if parents don't trust you, right? If they don't feel respected, or if they experience just really intense guilt and shame when they're talking about their kiddos with you or about their life with you. There are lots of feelings that most of us can tolerate for a good while, but shame and guilt are not feelings that any of us can tolerate for very long, right? And so again, when we are using language that is potentially increasing those feelings of guilt and shame, we're going to send people running away from us, right? Instead of bringing them to us. And I think one of the most important things that we can think about too is when you're having conversations with families about their kids, stick to the facts, right? Stick to what you know about child development. If you don't know, it's always okay, I promise, to say, I don't know the answer to that, but I know somebody who might, or you know what, let me do some research and I'll leave it in, Timmy's cubby tomorrow when you pick him up and it'll be there, right? And more importantly, just offer hope and have referrals ready if needed. So a little bit about the best way to talk about substance use disorders. So instead of calling someone an addict or a junkie or an alcoholic, right, you can simply say a person with a substance use disorder. You might even be able to say a person in recovery, right? A person in long-term recovery. Women fear being judged. And so the media's depiction of people with substance use disorder is stigmatizing, and it further contributes to fears of being judged by neighbors and their peers and other like community service providers. And the woman may also judge herself most harshly, right? So I promise they're judging themselves more than you could even imagine doing to them. And so there's a really great researcher from the University of North Carolina, Andre Jones, who specifically does research with pregnant and parenting women in recovery. And so I'm just going to read this quote because I think it sums up, most importantly, kind of how and why we avoid this really negative language. So I found out that I was pregnant in the middle of a relapse, and I thought I could not keep the baby. I did not feel motivated to keep the baby. I also felt shame and mortified in trying to get prenatal or drug treatment help. I knew they would judge me. They would also judge me if I lost the pregnancy. There was no way out. The thought of walking into a hospital and saying I'm using was terrifying. To tell somebody what you have been doing is scary and the hardest thing to do because you don't know how they're going to react, right? And so words are incredibly powerful, right? The way we interact with individuals can potentially welcome them into treatment and welcome them into a supportive environment or potentially drive them away, all right? And so another thing that we often hear when we're talking about individuals with substance use disorder, we know that lots of them may have to have drug screens periodically. And so what we can say is that they've had a positive screen or they've had an inappropriate screen. We try not to use words like dirty, right? We try not to use the phrase they passed a test or they failed a test, right? Recovery isn't a pass-fail situation. And it also, we want to talk about substance use disorder the same way that we would talk about other chronic medical conditions. And so we probably wouldn't use that language when talking about other medical conditions, right? And again, referring to someone as dirty really does increase those feelings of shame and guilt that are already present. So when talking about substances, again, instead of saying habit, you can use the phrase substance use disorder. Instead of, again, habit implies that they're continually choosing to use. And at this point, they're not, right? We know that this is a really chronic medical condition, just like other people aren't choosing to have other diseases. And it also really kind of downplays that the illness isn't super serious as other disorders. We also really try to refrain from using the word abuse. We've been really specific in talking about this as a substance use disorder, not a substance abuse disorder, because usually when we hear the word abuse, it brings up a very specific image in our mind, right? When I say the word abuse, I bet most of us probably think about somebody hurting someone or doing something wrong. It's also a really kind of criminalizing word, and we try not to use that type of language when talking about people who have a medical condition. Right. Also, I think probably one of the biggest things that has definitely come around since we've had such an opioid epidemic in Kentucky and really across the nation, but we've really felt the brunt of that in Kentucky, is we have had a lot of exposure to medications for treatment of opioid use disorder. So things like methadone or buprenorphine, or what people commonly call like Suboxone. All right. So that's not a substitution. It's not a replacement therapy, right? So those aren't substitutes for one drug or for one addiction, right? And so these medications are prescribed by a physician. They're monitored closely. They don't cause someone to be under the influence when taken appropriately, right? People are not becoming high, right? They're not under the influence from methadone or buprenorphine. So that's incredibly important to remember. They work very differently than when people are abusing other substances, all right? We also want to refrain from using the word clean, right? And I have to admit, when I first started in this field, that was pretty common practice, right? You would say, oh yeah, I've been clean so many days, or that person, oh, that's great. You've been clean for 75 days. That's amazing, right? That was pretty common practice. But when you think about that, that really makes someone's worth conditional on the result of a drug screen, right? So we're really calling people dirty or clean. Right. And so when you think about it that way, you can really start to understand how guilt, really builds up in someone when they're constantly referred to as clean or dirty. Right. And no matter if someone has had a return to use and they may not have a negative drug screen, they're still worthy of treatment. They're still worthy of services. And so we want to make sure that in our language and in talking with them every day, that we're promoting the idea that they have worth and that they're worthy of the services that our agency can provide. All right. And lastly, how do you refer to babies who were born to parents who were using substances? So, you can say a newborn exposed to substances, right? Or a baby with neonatal abstinence syndrome. If the baby has neonatal abstinence syndrome, not every baby who was born to a substance will have that. And so the most important thing is that we don't want to say addicted baby, right? All right. So I think most importantly, I love this quote from Cleo Wade. What we do and how we speak is either constructive or destructive. Choose to be constructive. Don't be a bulldozer where life calls on you to be a builder. And I think this is so true. Your words matter. Those small moments that you have when families are dropping their kids off or picking them up in the afternoon, those words build an ongoing relationship and really cement the idea that you care and you're there to support that whole family unit. And so, a little bit just about shame and stigma. Stigma is society's negative attitudes towards a group of people, and it's historically been pretty strong regarding issues of addiction. But as individuals who are working with families every day, you have the ability to foster long-term relationships, to count the wins with families, and to also have a hand on their backs when they're struggling with hardships. And they're going to struggle. We all do. So families living in recovery, they're not unique. They face the same struggles we all face. Loss of family, troubles at work, right? Unemployment, relationship struggles. Everybody needs encouragement and somebody to turn to when they're struggling. And you guys are definitely those people for a lot of families. Okay, and I'm going to turn it over to Amanda.
Thank you, Tanya. Thank you. So we really wanted to look at how you currently support families that you work with every day. And throughout this presentation, we kind of hopefully wanted to discuss some additional strategies that you could use when supporting your families throughout the presentation. So what are the signs that a family I am working with is struggling? A little disclaimer that we like to put on here. Not all of these are signs that a family may be struggling with substance disorder or relapse. Other factors really have to be included, such as lack of transportation and natural supports and so on. So there's really no magic checklist to show that people may be using. We wanted you to think about some of the experiences that you've had with substance disorders and recovery. Have you ever found yourself in a situation where someone you knew came out later as someone who has a substance disorder and you had no idea? So really focus on the fact that it could be anyone. It's always important to understand that substance disorder affects everyone differently. So no two people are the same. And although there can be signs of substance issues, some families may never show those signs and will not, quote, fit that mold of what substance disorders look like. It's when we really fit all those pieces together and we talk with that family, we can use this information to better understand the position that the family is currently in. So here are a few signs that a family I'm working with may be struggling. Are they missing appointments? Has someone missed multiple appointments back to back? Sometimes life happens. We all understand that, and we all miss appointments. Are they missing appointments back to back and maybe not rescheduling them? Are they no longer attending support groups or treatment? Was this person regularly attending those support group meetings and then suddenly stopped going? When I was early in my recovery, I attended support group meetings religiously. When I relapsed, I was so ashamed of myself and so embarrassed that I did not want to show my face there. I was blessed to have someone reach out to me and kind of pull me back in, but that was a sign that I was struggling in my recovery. Are they not taking their medication as prescribed? And whether that be a mental health medication or a medication for medicated assisted recovery, is this person stopping their medication, and why are they stopping their medication? Is it that they feel it's not working for them, or maybe they're struggling in their recovery? Are they unable to identify some of those natural supports? This is something that when I was new in my recovery, I had no idea what a natural support even was, let alone trying to identify somebody that was there for me. If I was struggling and fighting with my family, I would find myself in a place where all of a sudden, all the people I thought were natural supports were no longer there. So I would find myself in a place where I didn't have quote unquote natural supports. Do they have a lack of confidence? This is kind of another big one. I feel like this whole presentation is about me all of a sudden. So when you're up, but when you're down, and you're all the way down. Listen to the language used by the families that you're serving. Do you hear things like, I will never get any better. I will never get my kids back. This is useless. I'm never going to be, quote, normal. This kind of lack of confidence in oneself can be a driving factor in the progress that they make toward recovery and their confidence in really getting in there. Are they focusing on problems and not solutions? I think we're kind of all guilty of this sometimes. Sometimes our problems seem so big that we can't find a way to a solution. When a person is in recovery, especially early in their recovery, every problem seems to build on top of another. And it just becomes so very overwhelming. And we begin to lose sight of trying to find the solution to the bigger problem. Do they have a lack of motivation to move forward in the recovery journey? This is another one that really hits kind of close to home for me. Early in my recovery, I found myself in a place where I felt I was unable to move forward. It seemed like everything just stopped progressing. And I've heard this with a lot of other people in my support groups as well. I was working a case plan and attending meetings, but my life was kind of at a standstill. I found myself kind of lacking that motivation to continue forward. And I felt that I would never be able to have the life that I truly wanted to live. It took a lot of support from my supporters to really encourage me to continue on my journey and give me that support to move forward. Are you unable to contact the family by phone or emails or text? When I was struggling, I would miss appointments or meetings, and I would avoid my treatment team like the plague. I was embarrassed and kind of ashamed of myself. And it took a lot of constant phone calls from my team and reassurance that they believed in me to keep going and keep moving forward. And, are your families expressing that lack of hope? Is your families expressing that lack of hope, that they're saying things like, I feel hopeless, or there's no hope of me ever being in recovery. I used to feel normal because that's all I'm going to ever get. I used to tell families that I worked with when I did peer support, something that someone told me: if you can't hold the hope for yourself and your family, then I'm going to hold it for you. And whenever you're ready, I'm going to give it back to you and let you hold it for yourself. But until then, I want you to know I'm going to hold that hope for you and your family. You have someone on your team in your corner. And sometimes it just takes that one person to really show someone that you really believe in them. And that really does make all the difference. So how can peer supporters help families? Peer support is something close to my heart. It's something that started me on my journey. I received peer support services for years and then did peer support for another 8 years. So it's something special and close to my heart. So how can peer supports help families? Peer supporters have been there and they've really done that. They have that lived experience within the system of care. They have that experience in navigating these systems and coming out of the other side of these systems. Peers can share their stories and relate to families who are going through similar issues. When peer supporters share their stories, they show families that recovery is possible. It's that I did it and now you can too. You can do it if I did it. Peer supports can assist families with system navigation and find local community resources. Peers know where to locate services and supports in their community because they use those supports in their community. They have used these services and supports for their own family. And then peer support really, like I said before, holds hope for families that they can recover. It's non-judgmental and it's peer to peer. Just like I mentioned earlier, if you feel hopeless and you have no hope, then I'm going to hold it for you. You have someone in your corner. So how can I share my concerns with families compassionately? Communicate with families in a way that demonstrates a collaboration, a joint effort to help their children thrive. Providing feedback to families about the positive and challenging moments you experience with their children. Having those honest and open communications with families, discussing those challenges as well as accomplishments and successes. Really showing even those little accomplishments. Hey, I know transportation is an issue for you, but you made it to your appointment today. That is that's awesome. That's great. Approaching scenarios with the idea that most people are doing the best they can with what they have and what they have been taught. This is important when working with families as well. We all have those normal everyday lives, and coming from a point of view that everyone is doing the best they can really puts so much into perspective, coming from a place of positivity and understanding. And then put yourself in their shoes and really withhold judgment for understanding. A friend of mine who recently passed used to tell me, Amanda, withhold judgment for understanding. Understanding a family situation and what that family's went through and the challenges that they may face in the future. And I think when we really look to understand, we come from a place of strength and positivity and not from a place of weakness or looking at negativity. So I know we're running out of time. I'm sorry.
You're good on time. You're good.
Tanya, do you want to do this Mentimeter break? Ah, there it is.
Okay. All right. So you guys can go back to that same spot and just type in a few words about how you feel like you can best support a family in recovery. Amanda, you can hop in whenever you're ready.
Oh, okay. Wonderful. Tanya, you're such a wonderful partner. So let's take a look at this for just a second. How can I best support a family in recovery? And I know we have, I think, one in the chat as well. Listen and talk last. Keep trying. And as Tanya said earlier, the more people providing the same responses, the bigger the words get. So I see listen is pretty big up there. Encourage. Absolutely. Providing resources is another big one up there. I like these little ones too. Keep trying to reach them, being understanding, being there for them. Absolutely. This is
I
a
love
lot.
that somebody put accomplishment. I think sometimes, right, when you're really struggling and you're really in the throes of a challenge, someone noticing those like small improvements that you've made can be so encouraging. And I think, you know, kind of going back to what Amanda was talking about holding hope, man, you hold a lot of hope for someone when you point out those accomplishments along the way.
Absolutely. Sometimes it's just recognizing those little things that might slip under the radar. Awesome. That was a lot different than the first one we did, wasn't it? Okay, so moving on. So 3 takeaway points to serve families with respect. Number 1, to remember, substance use disorder is a chronic disease. Like any chronic disease, there may be flare-up of symptoms. Substance use disorder affects all types of people and affects everyone differently. Anyone can be affected by substance use disorder, no matter who they are or where they are from. And then the last one, although there are signs of substance use, that doesn't mean that all signs lead to substance use or relapse and recovery. Families may be going through something that is totally not related to substance use. This is when we need to really use that positive and strength-based communication to ask them how they're doing and kind of let them know that you care and that you're there for them. So here are some key strategies that you can use today. Number one, use person first respectful language when talking about substance use disorders. You know, Tanya talked about how important our language is when working with families. We want our families to feel respected and have that open communication with us. Number two, know the agencies in your community that offer peer support services to families living with substance use disorders. Peer support, like I said, it's where my heart is, but there are so many other resources as well available to families in their community. Peer support is just another resource in our resource toolbox. You know, peers have that experience that can relate to families that are going through those similar circumstances. And then initiate those conversations with families that you think may be struggling. Use a strength-based approach to offer that support and that hope. You know, families can be struggling with many different issues. It doesn't mean they have returned to drugs or alcohol. This is another great way to involve peer support specialists into that treatment team. Peer supports are able to really talk with families and have some of those difficult discussions because peers have been there and done that, and they can relate to families going through the similar situations. And then resources for families. I always got to put a little plug in here for Kentucky Partnership for Families and Children. They gave me my first opportunity years and years ago before peer support was billable, if that tells you how long. So KPFC is a statewide not-for-profit family and youth organization that provides multiple training opportunities and supports and resource information for families and youth throughout the state of Kentucky. KPFC also has certified family and youth and adult peer support specialists that provide peer support services. KPFC currently has 6 peer support centers throughout the state. Whoop, whoop. These peer support centers are run by certified youth and family and adult peer specialists. There is no cost or out-of-pocket expenses for the families, and they don't have to have a medical card to get peer support services. So to refer a family for peer support, you can visit the Kentucky Partnership for Families and Children website to fill out a referral. And if you have any questions about anything like that, I will put my email in the chat box, and please reach out to me. I don't mind a bit.
Perfect. Thanks, Amanda. And so just some more resources you can use. This treatment locator, findhelpnowky.org. It's an amazing resource. I encourage all of you to kind of like bookmark that in your browser. You can narrow down, do you want a treatment provider who provides medications for opioid use disorder? Do they serve only women? Are they trauma informed? Is it 25 miles from my house, right? Like you can search for all of those things and really reduce barriers. I can't talk enough about Kentucky's HANDS program. If you're working with families who have those small children less than 3 months, then making that referral to the HANDS program is imperative. That extra support and knowledge that first time or maybe parents who haven't been parents in a long time may need is so important. And I think one of the things that we know about families is that we can all use more support, right? I think if COVID-19 has shown us anything, we all need a bigger village. And so this is just one more person to add to that village. The Kentucky Moms Maternal Assistance Towards Recovery Program, or Kentucky Moms Matter, those are all run mostly through your like community mental health agencies. So Mountain Comprehensive Care or Adonta or New Vista in the Southern Bluegrass region. And so those offer case management services to pregnant and parenting women with substance use disorders and can really connect them to some great resources, some financial resources, housing, and things like that. And then some websites to avoid that stigmatizing language, just so you can kind of have that in your toolkit and share it. You know, sometimes, I work in the healthcare field, and unfortunately it's full of a lot of stigmatizing language. And so sometimes I just do a lot of education on a daily basis. I hear somebody say something, and when I reframe that, I reframe it back in a much more positive and respectful way. All right. And then there's our contact information too, if you have questions. So sorry, I think we ran a little bit over. So sorry, Caroline.
Do you want to go ahead and talk the Child Challenge? Great.
Good. All right,
Yep.
Good deal.